We use DM drugs to treat heart failure. How do we organize the sequence of each drugs? And why do patients receiving therapy have a higher chance of getting hyperkalemia? And how do we monitor the other side effects? In this video, our main focus is on the primary pharmacological therapy for patients having an LVEF of 40% or less, which categorized as HFrEF stands for heart failure with reduced ejection fraction. So, now let me introduce the Fantastic Four.
Holy crap.
Read. Well, not this one. Let me tell you a story first. The man in red symbolizes the heart with failure. He's sprinting through a forest, battling exhaustion, fully aware that stopping means succumbing to the looming threat of death. Despite his efforts, the relentless specter of death inches closer with sinister laugh, taunting.
Got you! Where are you running to?
The heart responds defiantly, I'm running back to my school.
Huh?
Yes, running back to my school. RAAS antagonist, beta blocker, MRA, SGLT2 inhibitor.
What? What are those?
Those drugs are the Fantastic Four for heart failure. Yes, we have a combination of several drugs that have shown fantastic outcomes for HFrEF patients, supported by extensive research. Once HFrEF is diagnosed, we initiate therapy as soon as possible. Typically, we start with R to B to M to S, selecting one medication from a specific group to initiate treatment. After 2 to 3 months, we may introduce another agent from a different group, and so forth. This approach allows us to evaluate how well each medication is tolerated. Importantly, once we commence the therapy, it is a lifelong commitment. Stopping the medication can lead to a decompensated heart failure for some individuals, even if the systolic function improves. There's a risk of recurrent heart failure. First, we are going to start with RUN. RAAS antagonists such as ARNI, ACEI, and ARB for the initial phase of the therapy. Following a myocardial insult that leads to left ventricular dysfunction, the RAAS becomes hyperactivated. Therefore, we require antagonists to make it calm. How do I determine which one to choose? Let's start by considering SV as the first priority. We need to ascertain if there are any barriers to start SV. As the name implies, it's related to the RAAS system. To understand its potential, we should think about what the RAAS does and then consider the opposite, as the antagonist essentially plays a reverse card. The angiotensin II will increase the BP, right? Reverse! SBP cannot be too low. It's making potassium excretion, right? Reverse! Serum potassium should not higher than 5. It's nearing the upper limit. It also makes H2O reabsorption, right? Reverse! eGFR should not be too low. Another crucial point, for unknown reasons, as we might cause angioedema. So, no, there's no reverse here. It's about thoroughly checking the medical history to ensure the suitability of SV. None of those found? Cool. You may start the SV now. If unfortunately the patient is not fit for SV, we will then consider ARBS and ACEIs. As long as the SBP is above 90 mmHg, it is important to remember that ACEIs can increase vascular permeability and cause vasodilation, potentially leading to angioedema, just like SV. Also, if transitioning between ACEIs and SV is necessary, please note that one of those should be omitted for 36 hours to minimize the risk. However, if the SBP is lower than 90 mmHg or residue decompensation occur, you may need a heart failure specialist. Alright, next. Running back to my school. B. Beta blocker, including metoprolol, carfentanil, and SSR version, or bisoprolol, but not including the other beta blockers. Are you having a big question mark in your mind now? It's like, what if the beta blockers cause hypotension and bradycardia, right? Could it worsen the hemodynamic status? Well, no. That's a misconception. You see, left ventricular dysfunction doesn't just hyperactivate the RAAS, it just affects the sympathetic nervous system. Beta blockers work to reverse the neurohumoral effects of the SNS. In the long run, this leads to improvements in LV function and structure. So, how do we start? We begin with a low dose, and then we double up every 2 or more weeks until reaching the target dose. During the initial titration, the patient may not tolerate it well. No problem, we can opt for a slower or delayed increase. However, if unfortunately the patient can't tolerate even the low dose of the beta blocker, we may need to consider an alternative choice. Alright, moving on to MRAs. Simply put, they block the effects of aldosterone and like diuretics, making you pee. They facilitate your kidneys in moving extra water and salt into your urine, eliminating them from your body. We typically prefer eplerenone over spironolactone as it carries a lower risk of endocrine side effects, like impotence in males. For patients on ACEIs, MRAs help in reducing blood pressure and albuminuria. Since MRAs are potassium-sparing diuretics, they retain potassium. During MRA therapy, we aim to maintain serum potassium level below 5.5 without dosage changes. Adjustments to the dosage are made based on the serum potassium level. Patients with impaired renal function, those older than 65 years old, or with diabetes are at risk of hyperkalemia. Well, yes, we use DM drugs to treat heart failure. Let me introduce SGLT2 inhibitor, like dapagliflozin and empagliflozin, and we only use these 2 drugs. It may start before or after run-back MI. It means it may start before RAAS inhibitor or after MRA. As we know, it primarily serves as a DM drug. Mostly, it operates by blocking the SGLT2 in the proximal tubule of the nephron, thereby reducing the reabsorption of glucose and sodium into the blood. This action leads to a decrease in the concentration of serum glucose. Oh wait, how do it help your heart? A. It decreases RAAS activation, resulting in reduced vascular inflammation and subsequently slowing down the progression of heart failure. It helps your heart.
Thank you so much.
You're welcome.
B. By reducing RAAS activation, it alleviates strain on blood vessels. This leads to a decrease in blood vessels, subsequently reducing cardiac workload. Overall, it helps your heart.
Thank you so much.
You're welcome.
C. SGLT2 inhibitor can suppress the adrenaline nervous system, resulting in a reduction of heart rate and blood pressure. It helps your heart.
Thank you so much.
You're welcome.
D. You pee more, right? It reduces your intravascular volume. It helps your heart.
Thank you so much.
You're welcome.
E. SGLT2 inhibitors cause an increase in circulating ketones, a byproduct of breaking down fat. Ketones serve as an energy source for the heart. Therefore, more ketones means more power for the heart, leading to less oxygen demand and ultimately reducing cardiac workload. It helps your heart.
Thank you so much.
You're welcome.
Do you hear that? Yes! The kidney releases more erythropoietin thanks to SGLT2 inhibitors. More erythropoietin means more red blood cells, resulting in more oxygen delivered to your heart. Well, again, it helps your heart.
Thank you so much.
You're welcome.
SGLT2 inhibitor! What a panacea, right? Right? Remember the ketone thing? It is not so infrequently. SGLT2 inhibitors can lead to euglycemic diabetes ketoacidosis. This means that even when your blood glucose levels are within or close to the normal range, you can still experience elevated levels of ketones in the blood and urine, ultimately resulting in acidosis. This condition is indeed very dangerous. The reason for this phenomenon is that when you take an SGLT2 inhibitor, your glucose level decreases, leading to a reduction in insulin secretion, with less need for insulin, circulating insulin level drop, resulting in an increase in free fatty acid production. The liver then converts this fatty acid into ketone bodies. Additionally, SGLT2 inhibitors stimulate more glucagon secretion, and increased glucagon levels further contribute to the production of ketone bodies. When the ketone bodies been too much, but the blood glucose normal or just a little bit higher than the normal. Boom. Alright. Now that we've explored how fantastic the Fantastic Four is, which includes Run Back My School, is there anything we need to be particularly alert or cautious about? Yes. For example, hypotension. Many HFrEF patients tend to have lower BP. Hiya. Should we adjust the drugs? Yes, but we do so only when specific situations are present, such as reduced exercise tolerance, pre-syncope or falls, and worsening renal function. So many drugs above are going to make the patients pee more, so it may cause hypovolemia. Also, hyperkalemia is a concern. Medications like ARNI, ACGI, ARB, or MRA. Prior to initiating or intensifying the therapy, if the serum potassium level is above 5, it should be managed. However, if the serum potassium exceeds 5.5, the therapy should either be stopped or the doses should be reduced. Moreover, the drugs are going to do different effects on the GFR. Sometimes may worsen the renal function. We have to reduce the risk of it, like avoid to use lifelong toxic drugs and volume depletion. So it's the end of this video. Let's make a conclusion first. Remember the story. Running back my school. Running back, RAAS antagonists and beta blockers are going to lower your BP. My school, MRA and SGLT2 inhibitors are to make you pee. Alright, before you go, if you find this video is helpful, please give me a like and subscribe. I will make more videos like this very soon. And here's my TikTok. I will share some nursing tips here, and it's my website. I get some very useful notes there. You may stop the video and scan this QR code to visit or click the link in the description below. I'm sure no matter you are a nursing student or already a nurse, you will like it. So, bye bye. See you in the next shift.